destroyed. You couldn't leave your unit.
Okay, so welcome to everyone who's joining us remotely. We are doing clinical protocols this morning, and as always, thank you to the Robert Johnson School of Medicine who provided some images for some of these sessions, as well as Cubase, which gives us license to use some images that were published there. So let's go ahead and start off. Brian, what do you see?
Looks like we got some flesh color to yellowish papules. My first thought was PXE because of the location and then the primary lesions.
So PXE would be an excellent thought, given that we're on the flexural surface and you have a little bit yellowy, maybe look to these otherwise flesh-colored papules, and it's called Pseudoxanthoma because of that appearance that it can have. What other things could be in the axilla? So PXE absolutely differential. What else?
Mm-hmm. I mean, you could think about more pigmented things like granular keratosis.
Granular keratosis tends to be keratotic. This looks like dermal papules.
Right. Pseudoxanthomas could also be.
Pseudoxanthoma, what if you biopsied and saw periapicrine or perifollicular xanthoma? What is that the histology for? Can you open up to the room? Any thoughts? First off, what else this could be? Fox fordyce. So Fox fordyce, which is apicrine biliaria, and what do you see histologically most commonly with Fox fordyce is from rupture of the duct. You see parafollicular xanthoma, which probably accounts for some of the papule and some of the yellow color in Fox fordyce, and some of the reason why you have patients who just dramatically respond to the birth control pill, and other patients who it doesn't respond so quickly and people give up on it, and it's probably just they're seeing those parafollicular xanthomas that don't go away real quick. Right? The biliaria respond.
Do you think retinoid does anything?
Retinoids are always used for this. And does it do something? It absolutely irritates. There's no question about that. In terms of efficacy, I'm not so sure. Botox has been used, but apicrine glands are not. Botox doesn't really affect secretion of apicrine glands, just eccrine glands. So it's not clear to me that either of those work. Pregnancy, it definitely improves. The birth control pill, it typically improves, but what you can expect to improve is the inciting miliaria component, and the parafollicular xanthoma may just have to run its course, which is fairly slow. And I think that's why you get mixed reports on whether the pill works. If that's what it was, but it would be a biopsy diagnosis. I believe this one was a Fox fordyce, but that's absolutely differential. Okay, Christine, what do you think?
So it looks like this is where their waistband is. Either it looks like either could be a really robust arthropod like a scabies underneath their waistband, or allergic contact to like the rubber. We talked about like putting your white undies in the bleach. That could happen.
Does it look more eczematous or more dermal?
More dermal.
More dermal. It's a little less, to me, a little less scaly, a little less band-like, more papular. There probably is a pressure phenomenon.
Like pressure urticaria, are you looking at?
Pressure urticaria. I mean, it looks like it's been persistent enough that someone did a punch. Probably. So, which implies that ultimately came down to a biopsy diagnosis. And it was similar to this patient, same diagnosis. So what would you think of this one?
This looks more like atrophic looking, like morphia, LSNA.
Morphia, LSNA, or else
GA.
is GA? Given the color, the fawn color. So is it atrophic? I think you do see the veins and reticular vessels more prominently through it. So I think there is a component of atrophy. Histologically, you see the attenuation of the dermal collagen bundles and replacement with MUSC. So there is definitely dermal atrophy in GA. I think you're seeing that here. The color, the distribution, the morphology, I think fit well with GA. In both of these cases for GA. When it has funny distributions like this, what systemic association should... Diabetes, yeah. And this was the first patient was a diabetic.
Is it more common under pressure, or is it just happen to be this photograph as
There
like
are often
highlighting?
inciting things. You see GA occurring with bug bites, minor trauma. Catheterization is really common for granuloma annulare. We used to call it necrobiotic bite reaction, as in, a dead ringer simulant of GA. I think it's just GA occurring as a Kevlar phenomenon. And it's not that uncommon. But unusual or widespread distributions of GA always screen for diabetes. Absolutely correct. Well done.
Alright, so looks like I have these annular patches with maybe some atrophy centrally. So it's hard to say.
I would say absolutely, given the visibility of the vessels.
Right. So.
And it looks like both epidermal and dermal atrophy here, because you have some increased light reflex, loss of skin margins.
Right. So like, you think of like Lyme disease, maybe like chronic atrophy.
So acrodermatitis, chronic atrophicanes can absolutely be annular, so it can be wider spread on distal extremities, or it can be the distribution of the original erythrochromical migraines.
Or atrophoderma.
Atrophoderma of Cassini and Perini. In terms of colors, what other colors do you pick up here?
Kind of like a reddish brown.
Absolutely. So it's always color distribution morphology. You described morphology pretty well. Distribution, this is shin. You said reddish brown. I'd say I pick up some yellows in here.
So like lipodermatosclerosis?
Lipodermatosclerosis, or what else? NLV would be. So if that's a typical appearance of granuloma annulare, this on the shin, related condition NLV, also diabetes associated, also a granulomatous condition with alteration of collagen. In granuloma annulare, it is atrophy of collagen bundles and replacement by mucin. In NLV, it is broad, devitalized, dead collagen. Hey, David, that's an axilla.
It's a macerated, corroded wax.
It actually may be any more crease, because that would be one skinny axilla.
Makes me think a little bit of something like Hailey-Hailey perhaps, or is it bad if bad could make a bad intertrigo, let's say.
So a bad intertrigo or Hailey-Hailey, and you are correct with Hailey-Hailey. The description that's often used is it looks like macerated tissue paper that has begun to tear, and you have blood red tears in the macerated tissue paper. Pretty good description. Correlates with the acanthosis, the dilapidated peripheral acantholysis, and the fissuring that you can see histologically as well. So Hailey-Hailey disease, patient is absolutely miserable, used to live in Alaska, recently moved to Charleston, One solution would be to move back to a climate that is less hot and humid. But for patients who have no choice but to stay where they are, how might you approach the Psoriasis, not so much, in my experience. So, can be a help in some dermatoses patients, but less so for Hailey-Hailey in my experience. So anyone else, upper ear residents, you know everything. So
let's Botox it, CO2 ablative laser it. You can do both.
The Dr. Elston technique.
So everything that you said. So first off, where I would start is topical steroids.
That's not as fun.
And anti-candidal agents, something like 2, but then you have to step down to a less strong steroid. The little bit of inflammation that occurs, a little bit of candida overgrowth, basically a little bit of trigo in a macerated area just tears apart this delicate skin. So patients can get significant improvement just with that conservative therapy. Then you have to do what you can to stop the sweating. Topicals are often not well tolerated. So things like aluminum chloride, better tolerated aqueous than alcoholic solution, but often not well tolerated at all. So then you go to, as you mentioned, Botox, but you can also use Granuloma. Exactly. So you can use anticholinergics to stop the sweating, and there are good published data that includes Hailey-Hailey. You can use Botox to stop the sweating, and there are good published data that just reducing that sweating and maceration improves it. The other observation made years ago is that the follicular epithelium is rarely involved. So if you do ablative therapy that destroys the entire surface epithelium and forces them to re-epithelialize from the follicles, they tend to get sustained benefit. And that is still commonly done with a variety of resurfacing lasers. Probably the best is if you have an old-style CO2 resurfacing laser that you can use in defocused mode. Some places kept them just purely for that and for actinic cheilitis. So if you're in focus mode, you burn. If you're in defocus mode, you just sort of bubble the epidermis and then it wipes away. It's been done with dermabrasion and with other resurfacing modalities.
Is Fraxel not enough ablation?
Well, the problem with Fraxel is it punches holes and leaves lots of epithelium behind.
There's too much of it.
And if it re-epithelializes, that's tough to say, from the remaining epidermis, it will have the genetic defect. Whereas if you get rid of all of that epidermis and force it to come from the follicular epidermis, you tend to have more sustained benefit. So that's my analysis of that.
So you have
So leukoplakia simply means a white plaque in the mouth. Usually correlates with something that macerates, something that has a defective barrier. So EBV, hairy tongue in an HIV patient would probably be at the top of the list. You would see if either is positive, and the clue histologically is a basophilic stippling of the nuclei, which is different from oral white sponge nevus. Oral white sponge nevus would be in the differential, but tends not to be hairy like this. This is definitely long filiform transactions. Post-antibiotic possibly can give you a hairy tongue. This really looks EBV like. So, and that first one is an EBV-associated oral hairy leukoplakia in an HIV patient, whereas this one is more of an antibiotic-associated black hairy tongue. But they can be yellow hairy tongue, green hairy tongue, white hairy tongue. after antibiotic use, usually associated with Candida. So how are you going to treat a post-antibiotic parenting?
Solutions
Looks
that
amazing
I
have a little geographic too. So anti-candidal things like Flucan, clotrimazole troches, all of those things work, but a lot of these people, they want it gone now. And
Just use like a tongue scraper.
you can use tongue scrapers, but tongue scraper alone doesn't work so well.
This
And
is your beef tenderizer thing that you
exactly.
like.
Just a little shake of tenderizer on the tongue. It's papain, it digests those elongated
Or an
portally.
entire plant.
Actually, pineapple does work. It's bromelain instead of papain, but those are
Fresh, not
proteolytic
canned.
enzyme.
Fresh.
I have a nugget off in my mouth.
Supposedly, pineapple pickers don't leave fingerprints because they're constantly visible with dermatoglyphs and all of that. It's true. The papain, so eating a lot of papaya, thank you. Papaya is what papain. So eating a lot of papaya and pineapple can help.
Musical theater and fruits. You
Eight-
got it.
Adolph's meat tenderizer with a toothbrush or tongue scraper works just fine. They do use it, I say 3 days max. I did have one patient who used it for 3 months.
Pretty tender meat, huh?
They did still have a tongue at the end. It was a little bit big and spongy, but it actually came back to normal in about a week. Okay.
This is me.
Yes. Or it is not you, but it is your turn.
I mean, so this makes me think of like Chillblains.
So Chillblains, absolutely right distribution. Color Chillblains often a little duskier, more violaceous, although it can be dusky red.
Some of those
Morphology.
are kind of
I'm not
the-
sure about morphology for Chillblains.
Yeah. Some of them have a good football shape for like Kaposi.
Some have an excellent elongated shape and appear white in the middle, suggesting there's some blistering component on the red base. And the distribution following dermatoglyphs is characteristic for Kaposi.
Am I trying to show us like the hand in the background that's just out of focus?
And
Yeah.
in the background, you may have an example, and if it is hand, foot, mouth, and backside, that would be a typical distribution for a Kaposi A16. How does Kaposi A6 differ?
It's like hard.
It's more widespread, and what is its characteristic distribution of groupings?
Perianally?
Often genital, perianal, but distinctly herpetiform.
Right.
So that it's often called eczema coxsackium because people look at it and they think eczema herpeticum. So people end up on acyclovir because someone's thinking eczema herpeticum with the herpetiform grouping. They're often ill compared to your usual patient with hand, foot, and mouth. It's attenuated some, but during the initial outbreaks, a high percentage of kids were hospitalized with Kaposi A6. They still tend to be sicker, and you get the herpetiform groupings.
If you look at pictures, Dr. Elston, how can you tell that verse? Normal, eczema, herpeticum, herpetic. Like, what are you looking for? What's your differences?
They don't tend to be umbilicated the same way as a herpetic lesion would be, but often it's the other associations and getting PCR for coverage. Sometimes you're not sure enough that you really need to confirm these things. So So that is sort of elbow region for an upper arm.
So, chronic process.
I would say probably chronic, yes.
Seeing what looks to be some mix. I see areas of scarring and areas that also look kind of atrophic as well. They look kind of cigarette, crinkly look of the epidermis above them, but then you have...
So you definitely have atrophy, increased light reflex, wrinkling. You have what probably has now a healed ulceration with each recovering. You have areas that are hyperkeratotic and acanthotic. This one would be more appearance. You also have, how would you describe this appearance?
So my first thought was like, this reminded me of like the igneous rock sign of like a hypertrophic lichen planus.
So igneous rock, which means it looks when you cut it away like there were little pockets in there. That would be in 3 dimensions. In 2 dimensions, one might say reticulated. White reticulated on a red to violaceous lesion that leaves hyperpigmentation. What do you think?
LP.
So, yeah, I mean that they look Wickham-Stria-like, right? So reticulated white, which correlates histologically to the beaded hypergranulosis. And so you have visible Wickham-Stria on a hyperkeratotic, acanthotic lesion. There's dramatic hyperpigmentation suggesting pigment dropout, suggesting it's an interface process.
Right.
So interface dermatitis, Wickham-Stria, looks like hypertrophic lichen planus, but what can be a dead ringer for hypertrophic lichen planus?
Hypertrophic lupus?
Hypertrophic lupus. How are you going to tell the two apart? The fact that this patient was in renal failure was so this patient had whipworm systemic lupus, as many patients with hypertrophic lupus do, but histologically they look the same.
What about itch?
Sometimes you get lucky with, so itch is a good point. Hypertrophic LP may be very pretty, but often it isn't. It's more tender, and there's a lot of overlap with lupus in terms of symptomatology for hypertrophic lupus. I'm sorry?
DIF?
DIF is golden in this setting. So not all lupus is positive with DIF, but all lichenoid hypertrophic lupus has a strong full house granular band of all components. So it looks very different from LP and is the never fail study to differentiate the two. Also look, if you see heavy eccrine coil involvement, if you see dermamucin, if you see basement membrane zone thickening, that will tell them apart. There was one of the cases presented this weekend at the dermpath meeting was a hypertrophic lupus where there really was a thick basement membrane zone as a clue that it wasn't lichen.
When screening these patients for SCC, how are you just seeing what isn't responsive to necessarily treatment, an ILK injection?
So the point you're alluding to is that this is the subset of lupus with the highest incidence of aggressive metastasizing squamous cell carcinoma. So it is a very real risk for the patients, a reason to control the disease, and exactly as you said, we treat aggressively to shut down the disease, and you start with antimalarial therapy, hydroxychloroquine, but some of these patients need retinoid, dapsone. Don't underestimate intralesional steroid for these patients, and some need to go on to a mycophenolate or other systemic agent. Anything that is not responding to therapy, especially if it appears more nodular, more indurated, ulcerated, should be biopsied to rule out squamous cell carcinoma. And this one was biopsied. That area, fortunately, was not swollen.
And then the new biologic for lupus. Do we have any data in that in cutaneous lupus effects yet, or is that all just?
So there are some data accumulating for the new biologic therapy for lupus, and in some subtypes of cutaneous lupus. It is effective. I'm not aware of data specifically in hypertrophic lupus. Absolutely, we are going to have refractory patients who are going to go on to that. I'm not sure we have enough body of data right
To know,
now
yeah.
to
I don't know.
judge.
I don't know if they have been studying it.
What I would do in a case like that is I call friends like Jeff Callan, who do a lot of rheumatologic derm, and probably have used it at this point a little more than I have.
You're going to be my friend, so you better. I'm not going to call Dr. Callan, I'll call you.
I will answer truthfully anything that I can, but we all need friends and we all call for help sometimes. Because people have specialty niches where they see more of a given patient, and so you call them.
Okay. I'm trying to look for the pathology. I see some idiopathic guttate hypomelanosis in the background here.
What looks like idiopathic guttate hypomelanosis. There's maybe a little hemosiderin type stasis.
See a little pigmented.
Maybe a few corkscrew hairs, but no hyperkeratosis, no parafollicular hemorrhage. So, the person may just have curly hair, or you might think the possibility of scurvy. You also have.
We're looking like
what's this?
Like more of a atrophy, a little bit extra. Are you?
Yeah, but what's this linear thing here?
I thought that was an underlying vein, so obviously.
So you probably think it's an underlying vein. It's a little bit linear for a vein here.
Okay.
And what if it's a nerve that's distinctly thickened?
So you'd be worried about a plexiform like neurofibroma?
So plexiform neurofibroma absolutely could give you localized thickening of the nerve.
Or tuberculosis, right?
You're saying tuberculosis, but you were actually thinking
is
was
leprosy. Sorry,
leprosy,
tuberculosis.
Because tuberculosis loves lungs and leprosy loves nerves.
Yes.
And sarcoidosis also can do nerves, although there are lingering questions how many of those nerve sarcoid patients who are leprosy that we've had trouble identifying. With PCR, more and more of them are leprosy.
So let me do that one.
So it looks like a large ulceration with kind of a violaceous border, overhanging border.
So a violaceous necrotic overhanging border on an ulcer.
Right.
You're leading the witness, sir.
Like PG, like cribriform
Like
pattern.
Pyoderma, gangrenosum,
Right.
and then you very cleverly picked up on the cribriform pattern of necrosis. Pyoderma gangrenosum, its initial onset is usually a suppurative folliculitis. At sites of needle stick, it can be pustular vasculitis, starting around dermal vessels. But more commonly, it's a suppurative folliculitis that turns into a pit that oozes pus and becomes necrotic. Those pits merge into a cribriform pattern, heal with cribriform scarring because of all of that suppurative folliculitis. Because of that, people often think furunculosis, they think infections. They're usually culture negative. And then how are you gonna treat PG?
So I should try like systemic steroids.
So systemic steroid is usually where you start because they respond rapidly. And then if they are refractory or if they're becoming pushinoid,
Like another like systemic immunosuppressant. Can you use like a TNF alpha?
so TNF alphas tend to work and you have to
What's
go
this?
pretty strong. So this is one of those cases where people tend to go right for infliximab rather than other TNF agents. What else works every bit as fast as infliximab?
Cyclosporin.
Cyclosporin is great in this condition. It's really fast. And then for patients who have a little more indolent disease, you can do things like topical steroids, topical cromolyn. Intraregional steroids you often get away with and it works just fine and you don't see pathogy from your injection sites. probably because you're instilling steroid at every site of potential pathogy. So all of those things can work. Dapsone can work in more indolent disease. Colchicine can work in more indolent disease. If you can't get a hold of dapsone or your patient has hemolysis, you can use azulfidine for the sulfapyridine, which may be, it is not as well tolerated in terms of dehydration. So in the South, you have to worry about kidney disease if you let them get dehydrated and they're on sulfapyridine. But it is a so what the easiest way to get sulfapyridine is azulfidine.
Yeah.
So azulfidine is salicylazosulfapyridine. The salicylic acid moiety remains in the gut and is not absorbed. The sulfapyridine is completely absorbed. And if you start at 500 milligrams 3 times a day, daily go up to 1.5 grams 3 times daily, you're dosing about where you would with sulfapyridine. So that, sulfapyridine has been easy to get, hard to get, and it's been a real pain. But you can always get salicylazosulfapyridine to dose it that way. So those are things you can do in more indolent disease. And then underlying disease, what's the most common? So, taking all comers, idiopathic is the most common for PG, but the most common underlying disease would be inflammatory bowel, usually EC over Crohn's.
Malignancy or like paraproteinemia,
and then paraproteinemia,
IgA.
especially IgA paraproteins, probably come in second after that. One other thing to bear in mind is that angiocentric, angiodestructive lymphomas absolutely mimic the necrotic overhanging bilacious border. What they don't tend to do is the cribriform pattern. But that is in the differential for PG-like lesions and would be an important reason to biopsy.
Do they still have a bunch of newts, or is it pretty easy to just send them to biopsy?
Well, once they become necrotic, the problem is where you biopsy. So often you have 2 or 3 biopsies that were non-specific, lots of neutrophils that be treated as PG, and then someone biopsies more at the periphery, and you see the heavy mantle of atypical lymphocytes invading the vessels, and the diagnosis becomes obvious.
So where's going to be the most diagnostic?
Be charitable to all of those who miss the diagnosis of angiocentric angiodestructive lymphoma, because it will be you one day. Because it's one of those things that... And then, many of the patients, they've been on an immunosuppressive treatment of some sort, and they have lymphoma. But the truth is, I'm not sure I've seen any evidence that it hurt them at all. A lot of them are CD30 positive and are probably more like a type E LYP anyway that run a relapsing course. So you're often, you start them on therapy and they heal, and you think you healed their PG, but it's the relapsing course of their type E LYP, which is basically a self-healing form of angiocentric angiodestructive lymphoma. The more serious ones are the ones that go on more like a lymphomatous granulomatosis pattern. Exactly. That's where you're more likely. So PG biopsy is not to establish a diagnosis of PG, it's to rule out other possibilities.
Right.
And often it's more than one biopsy because it's more centrally to rule out infectious causes and more peripherally to rule out lymphoma, angiocentric angiodestructive lymphoma. And this is another PG, and you can see all those little cribriform. And when the patients show up, they come in with these pitted, basically grouped pits oozing pus is a common presentation for active early lesions of PG.
So you mean like tissue culture inside the ulceration, and then just like an H&E Jason? Or are you saying?
Tissue culture and H&E from the center, and H&E alone from the periphery is what I would do. Yep.
Dystrophic toenail, great toe, and loss of the nail plate.
So you said dystrophic with loss of the nail plate. I would counter that I see a nail plate here, and it is under all of this stuff on both sides.
So that would be pterygium usually goes over the nail plate.
So pterygium would be an extension of the proximal nail fold scarred down to nail bed and matrix, which would be basically this fleshy pink tissue extending in the same distribution. This is kind of an inverse picture where you see the nail in the center and then you have all this stuff on the sides. So any upper ear when they're jumping?
It's like tuberous sclerosis.
So tuberous sclerosis, Keenan's tumors, angiofibromas tend to be proximal nail fold.
Is it a ventral pterygium?
So there are ventral pterygium and inverse pterygium at the distal portion of the nail associated with scleroderma, but that would be really a scarring of the hyponychium to the undersurface of the nail. In this case, you also see purulence. This is all just granulation tissue.
Chronic.
You got an ingrown nail. Ingrown nail with masses of granulation tissue. So the...
Oh, it's like that.
Yeah, exactly. The nail's under here. You've got basically a pincer nail that's ingrown, and then you just have massive granulation tissue and pus and purulence, and
your nail blocking and
feels
take
like
off
it
her
looks
nail.
like it would feel. So typically you block down the digit. I usually do a digital block at the base of the digit first, through the web space, and then laterally at the proximal joint. After you've done that block, then I do my wing block. So you basically double block them. And the wing block does two things. It does hemostasis without the need for a tourniquet, and it also provides good anesthesia. Even with all that blockade, what you don't tend to get is anesthesia right at the end. Fortunately, here you probably don't need to do a lot of work right there. Once it's blocked down, you just shave off or curette off all this granulation tissue, and under there you will see the pincer nail. And you don't have to take off the whole nail plate. What you're doing is you're taking the lateral portions of the nail plate on both sides, leaving a narrow rectangular nail plate in the middle.
Would you take it all the way back to the matrix on the side?
And usually the patient at this point wants a matrixectomy. For a lesser pincer nail, you can take an old credit card, cut a piece of it, and super glue it to the nail. The credit card then wants to regain its flat shape, and so it's constantly pushing up on the side, pulling up on the sides as the nail grows out. There have been numerous articles about that, many of them with tips on how to explain to the patient that you're asking for their credit card. Yes. But an old credit card works really well for that, super glued to the nail, a piece of it. For, again, milder disease, always ask if they've been on a beta blocker, because there are a variety of new drugs with beta blockers being at the top that are associated with acquired pincer nail, often multiple, and change of drug therapy, may be an important part of that. And in this case, we just avulsed the nail. Well, but the patient was so miserable. Take it off. And, even with the post-operative discomfort, your patient in a couple of days was just so grateful. Things were much better, because you just can't function with the they're pretty awful. Okay, what do you think? So scrape it for tinea crus. And there is a little scale at the periphery, so that's definitely worth doing. To me, it's a little wet looking atrophic dry for tinea crus. I would wonder if someone has been using steroid or if they've been giving the steroid antifungal.
Like a betamethasone, clotrimazole combo.
Betamethasone, clotrimazole, which often creates a lot of atrophy and complicates things. What other things would you think? So it could be bad intertrigo, inverse psoriasis, and that's one where, having been given the betamethasone and clotrimazole may actually have been
Helped
a
it.
good choice. If it were, that used in a pulse fashion on weekends can be great for inverse psoriasis. Otherwise, you probably start with desinide because it doesn't have a lot of protein glycol, and together with first generation, like clotrimazole, first generation imidazole. Later generation drugs get less and less candida spectrum. Early generation cheaper ones have better candida spectrum. It's a little white here. You'd wonder if that's just atrophy or if that could be LSNA. So you might biopsy for that, and you're likely to do a biopsy looking for inverse psoriasis.
Didn't you say it could be spongiatic only?
So inverse psoriasis so the types of psoriasis that always show spongiosis: acral, erythrodermic, inverse, and guttate. But you'll also see mounds of parakeratosis with neutrophils on top of them, and often sandwich sign alternating roots and para. You just accept that the spongiosis is normal for psoriasis in that site.
Okay,
But
you get all
other
the other
features of psoriasis are commonly there. The dilated vessels in the papillae, the rouleau of red blood cells within those vessels, all the subtle signs of psoriasis.
So this looks like the forehead of an old person. So it's like a impetiginized tumor of some type.
Looks like a secondarily crusted or impetiginized tumor, and definitely looks like a multi-lobulated tumor of some sort, so like a biopsy. And that one was a basal.
Still me, or?
Yeah. I guess that it must be
Basal cell.
He just said that was an easy button one.
What is the
It's not biased. It's in the German
Third years took it.
Yeah, I think they third year.
I
The
think
chiefs
Ron
just
said
took
something
it. They're
about
like
trucking, yeah.
Ron took it with him.
his residency was just.
It's a checkout.
So there's general acknowledgement that you deserved
So do you think it's me? This one I'd kind of put in that same spectrum. You have like just an ulcerated tumor of some sort, favored basal, like a rodent ulcer almost.
Yeah, and this one actually was a keratoacanthoma, with this being keratin filled. Is early keratin. And then this would be a little bit later in phase. So this one, there's induration all the way up to the glabella and into the columella, and basically the whole nose is affected. So how are you going to manage this keratoacanthoma?
So I'm going to need a really good dermatopathologist to call it a KA because I have a sneaking suspicion I probably wouldn't take a full biopsy of this one. If I was clinically confident enough to just call it a KA on exam.
Okay. And you want to rule out things like lymphoma that could mimic that. But if it comes out as, say your
A squamous-
pathologist says well-differentiated squamous cell carcinoma,
And I've seen this.
some features of KA, but there's no acantholysis, so nothing that says, this is definitely going to be like spleen.
Then I would inject it with some methotrexate.
So inject with methotrexate or 5-FU, or if it's too big to inject, there's nothing wrong with putting people on psoriatic doses of methotrexate, which is what's done for giant KAs. Or even 5-FU under occlusion if a patient can't tolerate. Basically, you're trying to save as much of the nose as you can for reconstruction. And so this is absolutely a case where intralesional methotrexate or 5-FU might be just the thing. It's, you do it on noses, eyelids, you do it on the shins of old women, where if you take one KA off, 5 come to the funeral, and you do either chemo wraps or you do injections with 5-fluorouracil methotrexate. And some of those people, where it's really eruptive all over, you do oral psoriatic doses.
Do you dilute the methotrexate when you inject it, or do you just
straight out of the bottle? Same with the 5-FU. So methotrexate is 25 per cc, 5-FU is 50 per cc, but you're usually using it straight out of the bottle. If you're doing a particularly large lesion, then I do dilute. I don't want to use more than 25 milligrams of methotrexate or 50 of 5-FU if I can help it. So, that's a full cc of methotrexate, which is actually a lot when you're basing. Yes, I mean that's actually a lot, a full cc. And even a half cc of 5-FU, because when you're injecting into the base of these, if there's no blanch, you're just injecting into keratin, and you're not accomplishing anything just injecting the crater. There's probably also no harm to the patient because it's just sitting in the crater. You're injecting to get an immediate blanch, and that tells you you're in the proliferative epithelium. And it really doesn't take that much liquid to get that blanch and to get a response. Okay.
Have you ever given intralesional methotrexate and 5-FU in the same lesion at the same time?
So have I ever used both? I have not done that. I've combined both with corticosteroid. I have not combined the two together. The toxicities are somewhat different other than human logic. I suppose if you're pushing upper doses, that would be something you could do. I'd probably go to the literature and see if there's any basis for it. I just I haven't
heard about it on the podcast.
You heard about it on the podcast? Not for me.
No, this podcaster.
I see. Meaning other people are going to say, well, I've heard it on the podcast.
This one time at band camp.
Changing what's possible.
I have no experience with using those two together.
So this is a violaceous plaque on, looks like the upper arm.
Okay, so you said violaceous and plaque.
It looks like firm, like it looks like I could
So it
feel
looks indurated.
Yeah.
And some may be papules, some may be plaque. They're certainly kind of elongated, and in terms of shape?
It's like, that is very linear, almost like Kevnerized or some sort. But I don't
So linear, but is it the same diameter at the ends as it is at the isthmus?
No, it's like a bell shape.
It is definitely dumbbell shaped. So distinctly dumbbell shaped and distinctly aligned along skin tension lines, this being an axilla. And you definitely picked up violaceous, but what other colors there?
Brown.
Brown. And what things can give rise to brown in the skin?
Hemosiderin.
So hemosiderin. what else?
Lipophages and
So lipofuscin
sorry.
or melanin.
Melanin.
So, so you run down. That's one way to do differential. Is I see dumbbell-shaped indurated lesions, distinct tendency to follow skin tension lines, has a brown pigment, so that could be hemosiderin, melanin, or lipofuscins. So then what are the possibilities under each of those categories? So can you think of anything that would look like this where it would be melanin? Or lipofuscin? So how about hemosiderin?
We need a fun kind
Anyone need to jump in?
Lymphoma,
It's like KS. So, to me, this is virtually diagnostic of KS because you guys see old man KS more commonly now. During the AIDS epidemic, this is what KS looked like. It was described as having a PR-like distribution, mucosal and PR-like on skin, distinct tendency to follow skin tension lines, oval, elongated lesions. They become dumbbell, just like keloids do. And then you see the various shades of red heme, violaceous, dusky, deoxygenated heme, and hemosiderin.
Thank you, friends.
And then this again could be a KS lesion, maybe more of the old man KS type that you see hemosiderosis at the periphery. And these again could be elongated lesions of KS, and this again could be epidemic type KS, which is not always HIV associated. You just need the HHV8 to get it. Okay, this has some similar shades, but also has some other shades of color. What else do you see there?
So it looks like some areas look atrophic, like in the bottom left, maybe.
Okay, I accept that.
Kind of a whitish reticular pattern in the upper central portion, maybe.
Okay, what other color?
Kind of yellowish.
Yellow. I'd say distinctly yellow there. So what things can give you yellow?
Like a xanthoma.
So
Like a eruptive
so lipid
xanthoma.
can give you yellow. What else can?
So like a another one.
In a jaundice patient, that's causing
Oh,
yellow.
like hyperbilirubinemia.
Bilirubin, and then localized bilirubin comes from breakdown of heme. So bruises become green and yellow as you get bilirubin and bilirubin. So, heme breakdown or lipid would be probably the two most common causes for yellowing skin. So I see things that have shades of purple and brown as well as yellow. So again, heme might be red blood cells, may be a common theme here. And this one, I believe, turned out to be leukemia cutis, with breakdown.
It's like on the volar wrist.
So volar wrist, correct.
Monomorphic, pink with flesh color, shiny papules.
So small, monomorphic, pink to flesh colored. You're picking up on the fact that they have a little light reflex, suggesting a little surface atrophy.
Distribution's good, like T, but they don't look.
Distribution is good for lichen planus, but as you said, they don't look like lichen planus, they look like lichen nitidus. Very good. Exactly correct. Little ball and claw, which is why they're such tiny little things. Okay, patient being treated for horrible stasis, dermatitis, and ulceration, getting various uniboots applied. Not responding well.
Biopsy.
So would be a reason for biopsy. Could be things like ulcerative necrobiosis lipoidica. As the uniboot was being changed, a more nodular component was noticed. This is a 95-year-old woman. What do 95-year-old women get on the legs? Leg type lymphoma, absolutely, which is what this is. This is our last one because of time.
So this is that same colors we were talking, like those lymphoma cutis.
So same kind of colors. Again, you have green and yellow, brown, violaceous. So I'm putting those together and suggesting some kind of heme, some kind of heme breakdown. So this could be leukemia cutis. This could be a hobnail hemangioma. It's not particularly targetoid hemosiderotic, but not all the hobnail hemangiomas are targetoid, so it could definitely fit into that category as well. Okay, so this is where we're going to pick up again. And so the last question is, how would you describe this morphology of broken rings? Race, nose, libido, correct. So before the next session, we get to read about race, nose, libido, so that you will shine.
It puts me in the hot seat.
Yeah.
So,
What are we on?
everyone, except that sometimes he's turned the universe on its head.
Start with James. Oh no.
Okay, so thanks to everyone who joined us, and we'll see you next time.
What is the number?
Oh.
That we're finishing on?
Let me